Thank you for being here.
Sure. Hi everybody. It's really good to be here. Brandon, my understanding is we're here until 4:30.
Yes.
Okay. So yeah, I practiced this a couple of times. I'm not exactly sure how long it's going to take, but my hope, I think what I'm thinking is, as I'm giving the talk, like if there are any big picture questions, maybe we'll save that till the end so that we can maybe generate discussion. But if there are any clarifying questions where like I'm saying something and you don't really understand it or it's not clear and like you won't understand anything else, if you don't understand that one thing, just interrupt me or raise your hand or whatever. We can always stop. I'm totally fine to do that. And then I'm also realizing that even though this pointer, yeah, I just realized that. So it's over here, and then you go, whoop, and then it stops. It's weird. So what I can do is, I'm thinking I'll just sit, and because I need to use the space bar to advance the slides, I'll just sit, and we'll just kind of present it like this, and then there are going to be graphs and pictures and stuff, and then I can get up and kind of point stuff out as we go. So I'll kind of be all over the place, if that's okay with you guys. All right. So just a couple of disclosures real quick. Nothing earth-shattering or incriminating. So in terms of the objectives of this talk, one of the really cool things for this talk, especially for me, is some self-disclosure, I've never had to give a job talk. Like Kate was saying, I've learned they call you E-Kate. Yeah. Yeah. So yeah, so like
that's right. We get rid of one Kate, we just call you Kate.
So like E-Kate was saying, I've really been at Mass General Hospital from the time I was a psychology intern until now as a staff person and hopefully the early part of my career. And so I've obviously had various steps to take to get to, from one point in my career to the other, but I've never had to like get up and give a job talk. So it sort of turned out that the studies that you guys wanted to learn more about were the ones that I did during my postdoctoral fellowship that were really focused on the developmental period of emerging adulthood, and I'll tell you a little bit about those studies. But this is essentially the talk I would have given if I was going to give a job talk after my postdoctoral fellowship and beyond. So it ended up working out really well, and it was a really cool experience for me to put these slides together. I've never put them all together for one talk like I have for this one. So yeah, really cool experience for me. So in terms of the objectives of the talk, it's going to focus on one data set of individuals that are 18 to 24-year-old, that are 18 to 24. I'm going to tell you about who they are, but they all went to residential substance disorder treatment in the Midwest. And the data were collected before I got to my postdoctoral fellowship. So they were collected between 2006 and 2008. I was a first-year grad student, my first couple years of grad school at the time. So it was really nice to have a rich clinical data set like this to come in and to be able to explore some of the research questions I was asking. And in terms of the objectives for this talk, a lot of the work, and you'll see as I go through it, it really kind of piggyback makes it sound like I didn't do the work. I did, but I was kind of dovetailing off ideas that my mentor John Kelly and a lot of the work that he had done, especially around recovery support services and other kinds of community-based resources like AA and NA and things like that. And so I was really interested at first in the moderating influence potentially of having a co-occurring psychiatric disorder. So in the first couple of talks, I'll lay out the outcomes from this residential treatment cohort over their first year after they left the residential treatment program. And then their participation in 12-step groups. I'll talk a little bit more about kind of what I mean and how we define that. And then my papers that I'll present more on, I'll go over the initial papers, but then I'll also talk really about my focus, which is on the young adults that have co-occurring psychiatric disorders. And then the third objective is to take a look at continuing care more broadly. So what were the different kinds of professional continuing care services that these young adults were seeking treatment in or were linked to after their residential treatment episode. So E-Kate, she kind of clued me in and to say, like, in terms of talking about why it's important to study emerging adults Dr. James and I had a conversation before, like I'm preaching the converted here, so I'm not going to spend any time on that. But one of the things I do think is interesting, and I have yet to write these findings up into a manuscript, and I do hope to. But for a poster, I looked at data from the National Survey on Drug Use and Health, the NSDUH, which is a yearly epi study that SAMHSA conducts, to try to get a sense, because there's all these studies from single clinical settings, and we amalgamate them to say, like, yes, emerging adults tend to have poor outcomes, they're hard to engage in treatment, they drop out more often, et cetera, than older adults, and sometimes studies even show more than adolescents. But I wanted to say, like, okay, when we look at a broad population, what really is different about emerging adults or young adults, which in this case were 18 to 25-year-olds, in terms of their substance use and their substance use treatment seeking? And without getting into the nuts and bolts of the data, because this is not really part of my talk, they really were like the age of in between, which is the title of my talk, and one of the ways that we refer to this group. In terms of their substance use profiles, they looked a whole lot more like adults 26 and up in terms of their severity. They had lower rates of alcohol use disorder, but rates of other kinds of disorders were similar or higher than older adults. Their injection drug use looked a whole lot more like older adults than like adolescents, and just in terms of the number of days that they were using. So there were all these markers of severity. They look like older adults, but when you look at their treatment seeking, they look like adolescents. So they're less likely to perceive a need for treatment than older adults. They seek specialty treatment at lower rates than older adults. And then when you look at their environmental risk, which in this data was defined as how often they were getting approached to buy drugs, getting approached more often than older adults as well, and more than younger adults too, or more than adolescents too, if I remember right. But anyways, the point is, I thought those were really interesting findings in kind of setting up the talk, in saying, like, they really are different, and not just at some single clinical setting or even a single kind of institution, but across the whole entire United States when we're looking at epi data. So I've become interested, even today, although it looks a little bit different, in, okay, so we know that they are an at-risk group. They're harder to engage in treatment, and their outcomes are going to be worse than older adults. So, okay, what do we do about that? Like, what can we do to boost their outcomes? And so these studies here are a lot about what are the kinds of services we can help link young adults to, particularly, or emerging adults, particularly after a residential treatment episode, that will help boost their outcomes. And then are there factors that might influence how much they benefit or not? In this case, I talk a little bit more about co-occurring disorders. And the reason, again, I'm probably preaching the converted here about the idea of co-occurring disorders, meaning co-occurring substance use and psychiatric disorder, is that it depends on severity, but typically when somebody's walking into substance use disorder treatment, that's my perspective, it's the kind of addiction treatment world when they have a co-occurring psychiatric disorder, as opposed to psychiatric treatment for those who have a co-occurring substance use disorder, different angles, same idea. Those who have a co-occurring psychiatric disorder do tend to have poor substance use treatment outcomes. As we go on in the slides, I'll talk a little bit about, there are nuances to that, like every other research question. But so it's important I thought that would be an important factor to consider. Emerging adults do have the highest rates of co-occurring disorders when you look at the SAMHSA data, for example. So I was thinking, okay, if there are particular risks for emerging adults who have co-occurring disorders, maybe we can identify some ways to help them better and then boost all emerging adult outcomes. And then they're a greater burden financially on the system because of the multiple conditions for which they're seeking help, and the ways in which having a co-occurring psychiatric disorder can be a predisposing risk factor for relapse and all these other kinds of complicating factors. So here's a little bit more about the data set. All three studies come from the same data set, so I just figured I would just review the data set real quick to give you a sense, and then we can always come back to it. So 302 18 to 24-year-olds all recruited from what's now called Hazel and Betty Ford from October 2006 to March 2008. They were followed while they were at residential treatment, which was lasted on average about 25 and a half days, or your typical 28-day residential treatment program. And then they were reassessed. So they were assessed at intake. They were assessed at mid-treatment. I don't talk about the mid-treatment data here at all, though. End treatment, 1 month, 3 months, 6 months, and 12 months after discharge. And in terms of the treatment that they were getting in residential, it's considered, at least at the time, state-of-the-art abstinence-based residential treatment. why do we call it state of the art? Mostly because they had a kind of psychiatrically integrated component. Everybody that walked into treatment got an initial psychiatric assessment on top of their substance use assessment. And if they needed other kinds of psychiatric services, they got them. That's kind of important to contextualize, I think, at least was for me, some of these findings. Fairly rich data set. Here's just a snippet of some of the measures that were collected in the data set. Sometimes I'll say we with the data set, but I told you guys I had nothing to do with this data collection. I was just very lucky. It's just a habit, right? And so here are some of the measures. And if you have questions as we're going through about how something was measured, I'm happy to go into it. One of the things just to point out, because it comes up quite a bit, is how we measured psychiatric symptoms. It was with the short form of the brief symptom inventory, which the long form is like the SCL-90. And so I'll talk a little more about it, but the scores, they're key scores, so they all have means of 50 and standard deviations of 10, which is kind of nice to help frame the results. A little bit more about the participants. This is also important, but they come up with limitations. So the sample was primarily white. In every single paper we've ever written from this data set, that's always like the first piece of the limitations. And so, and in terms of, we're talking about residential treatment, half of them were from areas of the median household income was below 56K. So they were not all wealthy. Some of them probably were. But when you're talking about residential treatment, clearly the family to really get a young person into residential treatment, the family had some kind of resources, or they knew how to navigate the system. They were able to use insurance. So that's just, again, it's just important to contextualize the findings here. These are fairly high-functioning families. I think that's the best way to put it, even though their SDS was pretty diverse. Compared to other kinds of treatment programs, as you might expect, they're more likely to be Caucasian, although they were similar in other demographic characteristics.
Can you say just a little bit about the residential, if it's how publicly funded it is?
Mostly insurance-based,
okay.
Mostly private insurance. I don't know. Yeah, I don't know the extent to which it's getting any public funding, but I know for the most part, private insurance. In terms of their substitution disorders, these were all derived from structured clinical interviews. They were DSM-4 criteria. So 3/4 met for each of 10 at the lifetime alcohol and cannabis use disorder, 45% cocaine, about 1/3 for opioid use disorder. And I don't know if it's large enough, but yeah, you see the pie chart is what they identify as their primary substance. Alcohol and marijuana were tied for first. That way, 28%, opioids 22%, and then smaller percentages of other substances. What this tells me is, so first of all, obviously, 2006 to 2008. So, and what you've seen since that time is more representation of opioid primary folks, especially opioid primary young adults when you look at the epi data. So that's something to help contextualize. And then, even though a smaller proportion had lifetime opioid use disorder, a larger proportion of them were identifying opioid as primary. So you have 22%, let's say 35% lifetime opioid use disorder, a little more than half were saying, okay, that's my primary substance, where those numbers were much lower for alcohol and marijuana. So for folks who had a lifetime opioid use disorder, it was fairly prominent in their substance. 47% of them met criteria for a co-occurring psychiatric disorder. Again, those were derived from the SCID. A third, now, I do talk about this a little bit, but just straight away, we did not assess. They did not assess for all psychiatric disorders, mood, anxiety, and eating disorders. So no antisocial personality disorder, no personality disorders at all, actually. And so there were things that, no psychotic disorders. And so what we see is, in this residential setting, their co-occurring psychiatric disorders, by and large, were mostly mild to moderate in nature in terms of the ways in which it affected their functioning. In fact, if they were actively psychotic, or even if they had bipolar disorder that was determined to not be sort of well controlled psychiatrically, they weren't allowed to enter residential treatment. So there's a selection bias in there. They were coming in with about 25% days abstinent, and those sub-bullets, ARMS is these are from a slide that from a slide that I gave it at Mass General Hospital, but I left it in here because I think it's important. ARMS is an outpatient program, and so what I'm showing you is, as you look, even though they're psychiatrically, they may not have been as severe as kind of adult samples and other kinds of settings for those with co-occurring disorder. From a substance use perspective, for emerging adults, these were pretty severe emerging adults. They were showing up for residential treatment, not because like they had one thing happen to them that threw their life off. These were folks who had pretty severe substance use profiles. They had high levels of dependent severity, much higher than outpatient young adults from our clinic. And they had substance use consequences that were similar to outpatient adults, a little bit less than inpatient adults, which again makes sense. When your using career has been shorter, you're not going to have accumulated as many kind of consequences. A quarter of them were hospitalized for substance use disorder in the prior year. More than half were arrested in the prior year. So now on to the studies. The first study is going to really talk about their experience in residential treatment and then their outcomes. Another kind of piece of self-disclosure, I'm a therapist. Both my parents are therapists. And so I, in a very loving way, like to make fun of therapy sometimes. Partly, I do think it's sort of like the adolescent in me who always resented having therapist parents. So I always like to put that joke in there when I'm talking about therapy. The patient is laying down on the couch and saying, "What do you say we blame your parents?" Not really. So here, I'll talk about that, and then the paper that I'm going to present really looked at the moderating impact or influence of having a co-occurring psychiatric disorder. So I'm happy to send any of the papers that these slides are referencing or kind of summarizing. So this paper, I was not a part of. This happened before I came on as a postdoc, and this was looking at during treatment changes in this sample. So just the changes that were happening in those 28 days. And what we see is on 5 clinical targets: psychiatric distress or psychological distress, that's the psychiatric symptoms; abstinence motivation on a 1 to 10 scale; self-efficacy on a 1 to 10 scale, which actually has self-efficacy scale that single item actually has a pretty good amount of data. My colleague Bettina Hepner has shown that it does a better job predicting abstinence over time than a 20-item self-efficacy scale. Abstinence coping, which is a subscale of a coping skills measure that was really developed for adolescents, but was used here in the study of emerging adults. And then commitment to AA and NA, which was part of the addiction treatment attitudes questionnaire, I believe. So, and what you saw generally in this, these are within group changes, no comparison group. You saw changes that are sort of medium to large. And what the title of the talk before the colon is ready, willing, but not able to change. So the idea is for these emerging adults that have had pretty severe consequences and substance use profiles, they come in pretty motivated to change their substance use, but their self-efficacy is a little bit lower, and so they don't feel confident in being able to do that. Residential treatment helps them increase their confidence to be able to stay abstinent. And then lo and behold, when you look at all the different treatment changes together in the same model and which ones are the best predictors of 3-month abstinence, just dichotomous, yes or no, were you abstinent over the first 3 months after treatment, self-efficacy was the only predictor that remained significant. It was the strongest predictor. And that was in the model with all 5 of these. So that's just the preliminary stuff. And then what I'll talk about is, I expanded on that study by looking at the outcomes, not just at 3 months, but 3, 6, and 12 months for substance use and psychiatric symptoms. And then I also looked at those during treatment changes to see if having a co-occurring disorder moderated those changes or made a difference. So just real quick in terms of the intake differences, right? We haven't talked about that between those who had a co-occurring disorder versus those who didn't. So females are more likely to be in the co-occurring disorder group, about 4 times more likely. These odds ratios are just bivariate. They're not adjusting for anything else. But the other demographics were all similar. And they were more severe. They had more consequences, higher levels of dependent severity, more psychiatric symptoms, as you might expect, when they walked into treatment. Similar on some of these other life experiences. And I'm not sure how informative the different kinds of substance use disorders they had were different, but for descriptive purposes, you see here, the COD group or the co-occurring disorder group were more likely to have alcohol use disorder, polysubstance dependence, which as we know doesn't exist anymore. It existed before, it doesn't exist anymore. And cannabis use disorder was more likely in the SUD only group. So in terms of response to treatment, these are Cohen's D estimates, and so they're side-by-side comparisons. I didn't include the model, but what I can tell you is that all those changes during treatment were similar for the COD group versus the SUD only group, except for psychiatric symptoms. And I'm going to follow up with more detail where the COD group had a bigger improvement or a larger improvement on psychiatric symptoms. They started out with many more symptoms, so it could be sort of a regression to the mean issue, which we'll talk about. But the take-home message from this slide is the COD emerging adults in this sample did as well during treatment on these psychosocial targets as the SUD-only folks. So now, I just think this idea, and this will come up in the future direction slide, and that's something I hope that sparks some discussion in the group, is everybody, when they walked in to treatment, were reporting some elevated level of psychiatric symptoms, even the SUD-only group. So I'm going to get up. So you have the SUD-only group here, the COD group here. The blue bar represents their psychiatric symptoms at intake. The red bar, their psychiatric symptoms at treatment discharge. And as a reminder, these psych symptoms were measured by the global symptom inventory of the BSI, the brief symptom inventory, and so those are T-scores, right? So this is about standard deviation above the mean, so I got like the 84th percentile, something going back to the SAT 101. So they were keeping a standard deviation above the mean when they walked into treatment, and the COD group was 2 standard deviations, roughly above the mean. And what you see is in just 25 and a half days, okay, you see this like precipitous drop in their reported psychiatric symptoms. So again, this is their subjective reported psychiatric symptoms. So now I'll move on to some of the other slides, but this will come up again, and I just think it's important to point out in terms of this precipitous improvement in psychiatric symptoms, both in the SUD-only emerging adults and those with co-occurring disorders. And then interestingly, right, in these models, we adjusted or controlled for baseline levels of each outcome, and we adjusted for other kinds of factors that might predict outcome in the way that we usually do, and factors that predicted attrition. So you had some dropout over time, and we tried to account for that statistically. And what we saw is that once we adjusted for those factors, the graph on the left is percent days abstinent, and you kind of just look descriptively, where the red bar is those that are SUD only, the blue bar, or the blue line rather, is the COD group. And you see, even though it looks like we're measuring them every month, we're really only measuring them at 3, 6, and 12. So that's why the lines look a little bit more straight than they were in reality. It'd probably be a little bumpier. But when we adjusted for those things, there was no difference over time in terms of response to residential treatment on percent days abstinent. One of the things to point out descriptively is if you look at 12, the 12-month outcome, you do start to see the COD group tail off a little bit. That's a teaser for the next study because it does come into play. And then the graph on the right, those are psychiatric symptoms, and there was a main effect, right, where COD folks had higher levels of psych symptoms throughout the year. But when you adjusted for the fact that they walked into treatment with higher levels of symptoms, they responded just as well to residential treatment as the SUD-only group. This was not what I expected. My hypothesis was one of those things where I had to say, counter to my hypothesis. That was not fun. And one of the kind of subsidiary or exploratory post hoc things that we did was to say, okay, we know that COD participants or patients responded as well as SUD-only patients. We didn't expect that. We also know they came into treatment more severe, right? So if you look at the clinical profiles, they were more severe when they walked into treatment, but they did about as well. Why? We don't know exactly what happened, but we do know that of those 3, psychiatric symptoms, substance use consequences, and dependence vary measured by the lead consequence they didn't take with a predictor of worse abstinence outcomes over time. And they did have worse consequences when they walked in. So it's possible, we can't say from these data, but one of the things that I hypothesize is there's something about the residential treatment program and the ways or things in which that residential program facilitated or linked them into doing after treatment that helped buffer against some risk that they walked in with. Hard to know exactly what happened there, but that's a kind of post hoc hypothesis that I hope to look at further or spark other people's ideas. Here are just 3 bullet points in terms of this study. I'm gonna skip this slide. We can come back to it because I feel like I want to just move on to the next study and give us enough time. But the long and the short of it is they changed as much during treatment. Their outcomes in terms of their response when you control for their baseline levels of the outcome, they also responded as well to the SUD-only folks. Some implications for treatment and recovery. Again, I'll kind of leave this to the end. But one of the things I have thought about is, one, it's just really hard to diagnose co-occurring really hard to diagnose psychiatrically. Folks that are walking into a substance disorder treatment program right after they're coming off of active addiction, they're all reporting really high levels of depression and anxiety. Whether those are like independent, whether they're like independent psychiatric disorders that will require their own type of treatment or attention, that remains to be seen. At the same time, maybe they are true independent disorders. They tried to rule out substance-induced disorders, so it wasn't like they didn't take history into account when they did a structured interview. One of the things that you've seen in some other studies is substance use disorder treatment that is not necessarily intended to be treating co-occurring depression and anxiety, not all co-occurring disorders, but it does lead to improvements in those kinds of psychiatric symptoms, especially the mild to moderate ones. For anybody that's ever done addiction treatment, we can't get away without talking about feelings, right? We're talking about depression, anxiety as triggers for relapse, as precipitating factors for the substance use, just all these sorts of things. And so one possibility also is that the treatment itself was treating these things, even though it's quote unquote a substance use disorder treatment program.
Can I ask you a very quick question? Can you just give us an examples of what's included in the measure of consequences? Just a couple examples of what.
Yeah. So it could be anything. It could have been like consequences with the law. It could have been people getting upset at you for relationships. It could have been work-related, lost a job, poor performance at school. So there are 50 items for that scale. It's a scale that was used in Project Match. So it's a 50-item scale, and it asks about frequency in the last 90 days, I believe, from 0 to 3. So it pretty much runs the gamut from social, psychological, medical, life events.
And do you have any way to disentangle the effects of treatment versus the effects of just abstinence on their improvement in symptoms?
Not in these studies.
Yes.
There might be some kind of more sophisticated ways to do that. We could talk about that during discussion, but yeah.
Okay.
Just as a side note, one of the things that there was a study that was done that might help answer your question. John, my mentor, he looked at so he's got this whole body of work looking at the mechanisms of 12-step participation, which I'll talk about a little bit. So the field started moving away from, okay, does it help? The field started to tell, like, okay, it helps, to for whom does it help the most or the least, right? Who do we have to really pay attention to? And then how? How does it help? How does it work? So John's got these series of studies, and one of them shows that it does help by sort of reducing depression, but not when you look at it over time, but not when you account for the role that abstinence plays. So in other words, you have there's a causal chain with 12-step to increase abstinence, to reduce depression, to more increased abstinence, for example, right? So, but if you just look at depression, it would look like, oh yeah, they're reducing their depression through 12-step participation, which is helping them get better. But it seems to be the fact that 12-step groups are helping them remain abstinent, which is reducing their depression, which in turn is further improving their abstinence rates. So that sort of speaks to your question. But with these data, we can. So here, this study, in the second study, I said, okay, so I have a good sense of their outcomes, but what kinds of things after treatment would improve outcomes, right? What are ways to boost their outcomes after they leave the residential program? So just a little bit of a background. I don't know how familiar this group is with 12-step research or mutual help research, and so I'll just talk about that a little bit, and then we can always come back to this. So the term that I usually use are mutual help organizations, or MHOs. Forever they were called self-help groups, but sometimes you'll also hear them called mutual aid organizations. So these are non-professional, peer-operated organizations devoted to helping individuals with addiction-related problems. Addiction, in this case, there are mutual help organizations out there for individuals with medical issues, for mental health. There's one called the Depression and Bipolar Support Alliance, or DBSA, which is here locally, which John, my mentor, has an R21 from the NIMH that he's studying kind of the impact of DBSA for folks with mood disorders. So they're not specific to the addiction world, but I would put forward that it's really the only aspect of healthcare where mutual help groups are just so infused with the treatment system. Because for those of you that you guys may already know, with addiction treatment. I really wasn't planning on talking about this, but I think it's worth it in terms of the background and understanding. So like the treatment program these emerging adults went to was a 12-step based program. They did incorporate other kinds of evidence-based treatments, but by and large, when you're talking about the residential treatment system in the United States especially, by and large, these are 12-step based programs. Part of that is because for a very long time, professionals in healthcare, whether they're psychologists or psychiatrists or other kinds of doctors, they didn't know what to do with folks with substance use problems, right? So in the 30s, when AA was created or developed by Bill Wilson and Dr. Bob, there were no treatments for addiction in the professional world. And so the treatment system for addiction grew out of this grassroots AA organization. And so there are just remnants of that everywhere. And like in the 80s and 90s, it's been a major professionalization of addiction treatment. And now we're saying, oh, no, we know ways to help now. We want it back. We being the professionals, right? But there's still this like major kind of integration that's impossible to separate AA and 12-step based recovery from the treatment system in the U.S., at least as it exists right now. So in terms of this program, the residential program really did make efforts to link the young adults to 12-step meetings when they were there. They took them to meetings, and then they really helped link them to meetings and recovery communities after the residential treatment program as well. So in 12-step groups, they all pretty much encourage abstinence as a disease model of addiction. The idea is that the substance use is a symptom of underlying emotional and spiritual difficulties. And there's this model of reciprocal helping. Like you guys have maybe heard of the idea of having a sponsor. That is present in at least 12-step mutual help organizations. 12-step aren't the only kind of mutual help groups. It's more regional, but there's Smart Recovery. Also, if anybody's heard of that, which is based more on cognitive behavioral principles of change. It was actually came out of rational recovery, which was based on Albert Ellis's, I forgot what it's called. But it's not like Albert Ellis's version of CBT. It'll come to me at some point. Yeah, REBT. Thank you. Rational Emotive Behavioral Therapy. He was on the saying like, you can't say should, you can't say could, or whatever. So there are other kinds of mutual help groups, but 12-step groups are by far the most popular kinds of mutual help organizations, and they are the most commonly sought service among professional and non-professional services of all substance use disorder services for people with substance use disorder. We look at the epi data. So, for example, you've got like 20, depending on the year, like 22 million people or 12 and up in the U.S. meet criteria for substance use disorder in any given year. Of those, about 4 million, a little bit less sometimes, are seeking some kind of substance use disorder services, right? And it's always about half those that are seeking kind of specialty treatment. But so when you look at that about 4 million, that group of about 4 million people, they're seeking a range of services: residential treatment, outpatient treatment. They could be going to their primary care doctor. They could be going to a religious counselor, et cetera. 12-step groups are part of that. And it is the most commonly sought of all the services. So when you look at that group of people, half of them had gone to a 12-step group in the last year. Compare that to 40% of whom went to an outpatient facility of some sort. That was second. So it's very common. And then there's been a very growing literature. Again, I don't have too much time in my slide to talk about it. I'm realizing I'm already getting wordy. So I'm going to kind of move forward. But we could talk about it later. There is a really solid evidence base for 12-step participation, especially for more active involvement relative to attendance, and I'll tell you what that means. And their cost benefits. So, for example, people have shown what?
I said clearly.
Oh, yeah,
it's free, right?
It's free, yeah. Exactly, it's free. But so even when you look at like professional treatments that are 12-step based, right? So there's this seminal series of studies by Keith Humphreys and Rudy Moose from the VA, and they did a series of studies to show. They did a quasi-experimental study using essentially matched groups of folks that were going to 12-step based treatment in the VA for addiction versus CBT based treatment in the VA for addiction. The 12-step group, they had outcomes that were as good or better at cost savings of like $3,000 per year per patient, because they were not using professional services as often after that initial residential treatment episode, the 12-step group. So they just were more conditioned to be using community-based supports. The last thing I'll say is just in terms of mutual help organizations, there is a pretty big literature on barriers for folks with co-occurring disorders. And again, it really depends on how severe the co-occurring disorder is. For patients that have psychotic disorders, there do appear to be barriers for them going and connecting. And also for adults in the VA, so these were men in their 50s. They had a bit of a tougher time showing benefiting, but by and large, when you look at mild to moderate mood and anxiety disorders, if anything, they appear to be a help. They appear to motivate people because they're struggling or suffering a little bit more, and so they try to get more involved. There are a few studies that show that. Again, my work on the co-occurring disorder side was dovetailing off of the primary study that John conducted looking at 12-step mutual help participation. It's going to be hard to see, but just really quick. This isn't the whole sample. This is when they walked into treatment 3 months after they were discharged, 6 months, 12 months. And this dark line is percent days attending any kind of 12-step meeting, AA, NA, MA they have here, Marijuana Anonymous. And you see, as you might expect, a spike, right? They came in with not that much meeting attendance. It jumps, and then they're going to a little bit less over time. These are raw estimates. And so here we're talking like, we started with 302. By the time we get here, we're talking about 212 people, right? And so they tended to be more well off. Just to put that in perspective, there's nothing adjusted with these lines. Now this line is a little more interesting to me. This is what we call active involvement, that dotted line. Active involvement is not attendance. One of the things that the researchers who have been my mentors and have come before me discovered was attendance does predict better outcomes. But what really predicts better outcomes in a much more robust way is how involved they're getting in the 12-step fellowship. That means, do they have a sponsor? Are they have contact with a sponsor? Are they making friends and spending time with meetings outside of the meeting? Are they making friends and spending time with these friends outside of meetings? Are they reading 12-step literature, et cetera? So this was a 0 to 8 scale. In any given follow-up period, they either did that activity or didn't. And so what you see is, by the time 3 months come up, and then it remains pretty stable, they're involved in 5 out of 8 activities. So this was a very involved group of emerging adults in their various 12-step communities. This treatment program was really good at getting them linked up.
Is it more common for the emerging adults? Because it sort of feels like
less. They're typically very hard to engage in 12-step groups.
What was so unique about this group that you have such a?
Well, they were more severe. And anytime you're talking about people with higher levels of severity, they're a little bit more willing to try new things. So that was one. And two, I do think that the clinical program there and the clinicians were really good at enhancing their motivation. Like if you look at AA and NA commitment, these are Cohen's D's. These are pretty decent sized effects. Again, during treatment in a single group, doesn't matter if they were COD or SUD only. They're more committed to going to AA and NA. Why do I think it works? When you go to these residential programs, they take you to meetings. And so you're exposed to this stuff. So these emerging adults are forced to confront their typically negative or ambivalent attitudes about 12-step groups. And they hear people talking, and they go, oh my God, I really like what this person's saying, or I sound like, I can relate to this person. And so it changes a lot of those attitudes. We think about it a lot as like kind of social contagion in a lot of ways, where they might see somebody and so they're exposed to what people in the field are starting to call recovery role models. And that seems to be a reason that people are changing their attitudes and beliefs. We don't know that that's what happened. It's just an idea I had.
I can't remember if the residential program is only for emerging adults.
This was a special youngest
too.
Yes.
Because usually they're one of the fewer young adults in a group of much older people, which is a huge turnoff.
This was a young adult specific residential program.
So they got exposure to AA among their peers, which could have gotten some.
It's unclear like what meetings they were taking them to. Okay. There was a study also from this data set where they asked them of the meetings they were going to in the year after, like what % of people were your age. And what's interesting there, right, is we see that going to meetings with more young people do help them engage. And that's one of the big barriers, right? Just to meeting attendance in general. When AA does their annual survey, 10% of them are under 30, right? And if we're asking them to get involved socially and to use those social connections to enhance their recovery, and there's nobody there their age, it's going to be hard for them. So there are these young adult meetings, and there's a question of, okay, if there are more people at a meeting that are your age, how does that work, or how does that change their benefit? So what it does is, with this group, they got more engaged earlier on, the more they were going to meetings with other young people there. It did improve their outcomes early on. By the time you got to 6 months and 12 months, they actually had worse outcomes if they were going to more meetings with young people. We think because there's something about being exposed to or forming relationships with people that are more experienced in recovery and are probably a bit older. They need those kind of recovery role models or recovery mentors along the way. But there is something to be said that they were more likely to go to meetings and to benefit early on. So there's something about that initial engagement and motivation by being around other young people, but there appears to be something about that might be iatrogenic over time, actually. But yes, the residential program itself, they were all young adults. Yeah. So what we see here real quick is there was no difference for the COD only group versus the SCD only group in terms of participation. On the left, that's percent days attending a meeting over the follow-ups. On the right, that's that active 12-step involvement, that 0 to 8 scale. You see basically virtually the same lines, same trajectories. Now, in terms of benefit, what we do see, and again, I'm going to get up real quick, these were the main models, and what we showed was there was main effective attendance, main effective active involvement, and it was a stronger effect. This 0.062 is of the weight. I'll get to that. Main effective active involvement. We looked at it separately, not together. These are two separate models. We saw the same thing. Now, in this case, the COD group, they actually had worse abstinence rates than the SCD only group. And you might remember from study 1 that I said they had the same. Part of what happened is that in these models, we only looked at 6 and 12-month outcomes. In the first model, the 3-month outcome was included. So that did something that the trajectories of the models. If you remember also that, I won't go back to it, but as you got to 12 months, the COD group actually started to tail off. And so if you just look at 12 and 6 at the same time, they do look like they're doing a bit worse on their abstinence. But anyway, the point of this slide is to show you that for the COD only group, the COD group, sorry, blue, SCD only group, red. For those, let's just look at active involvement. For those involved at high levels, having a co-occurring disorder made no difference. Okay, so they were similar. But if they were involved at low levels, the COD group did worse. Not quite significantly worse, but if you look descriptively, 85% days abstinent versus 67 or so, right? So what I'm saying is 12-step participation might help buffer against some risk for the COD only group, or for the COD group rather. If they're attending at low rates, they're gonna sort of be exposed or substitute whatever the burden of having that other psychiatric disorder is, but not if they're involved in 12-step groups at very high levels. Whoops. So yeah, I think as follow-ups, I do want to get a sense of like what's going on in the 12-step groups. One of the things that I didn't talk about here, but it's in the paper, is after we got this effect that was neat, it was not quite significant. We looked at it a little bit further. We saw what I showed you there, but then we also looked at these 8 activities of 12-step participation, and we looked at them individually, and we said, okay, are there any where the COD group seems to benefit the most from? In other words, we think that 12-step participation is sort of helping COD patients catch up to their SCD-only counterparts in a way. It's helping buffer against some of their risk potentially. When we look at the individual activities, of the 8, having a sponsor was the only individual activity and sponsor contact that predicted this interaction that we saw. So again, it's just worth following up, and we're thinking, okay, if we're talking about emerging adults that are also struggling with co-occurring psychiatric disorders, there might be something particularly helpful about having a sponsor. And if we're going to be talking about linking them with these 12-step groups, one, there are professional treatments called 12-step facilitations that have been shown to make it more likely for people to go to meetings, but there are some that are better than others about talking about the idea of a sponsor, what it means to have a sponsor, how to get a sponsor. And so one of them is MAZE is the acronym. It's Making AA Easy. Leanne Kaskudis' group created that. Four sessions real quick. But so I mean, the major way that people will make referrals to 12-step groups in the field of psychiatry, they just make a suggestion and maybe give them a meeting list and say, like, hey, you should go check it out. One of the things we know is that more intensive professional interventions get people to go more often and for a longer period of time and to get more involved. I think that's one of the things that I've been thinking about with emerging adults especially, is because naturalistically they're not very likely to go to meetings if you just make a referral. They don't see themselves as like the people that are at meetings because they're not severe enough, they're too old, I don't need to be there. And I also think there's something fairly anxiety-provoking about showing up to a meeting for them if they don't know anybody. Communication has really changed in a lot of ways, and kind of showing up to places in person without knowing anybody is not very common these days. I don't know if it was ever common. I know it's not common now. And that's really where my work has gone in a lot of ways more recently. And yeah.
In your age, my understanding is people can go to meetings and do all that stuff and be active, but not necessarily work steps.
Sure.
Like, so was that one of
that was one of the 8.
That was one of the 8, and
yes.
that didn't have a.
So one of the reasons now one of the reasons I often don't mention that in the 8 is because.
Sorry. Wow. Again.
No.
Sorry, I'm leaving.
There was like a disdain. There was like a tone of disdain in my voice. I didn't mean it to sound like that at all. I guess what I was saying is I purposely don't use that as an example because there's been a lot of studies more recently trying to understand which activities are the best predictors of outcomes, mostly in adults, right? And step work actually is not a very good predictor of abstinence rates, at least in the first year. Having a sponsor it's really the social mechanisms of change in 12-step groups are by far and away the most robust predictors or robust mechanisms of why or how 12-step groups work. I sort of suspect that step work might have benefits outside of abstinence, kind of for overall well-being, and they might be more long-term. I don't know. We'll see. But when it comes to abstinence rates in the first year, step work doesn't really make a difference. Yeah.
Did you differentiate between AA and NA?
No. So in this study, we looked at any kind of 12-step. Not only did we not differentiate between A and NA, we didn't differentiate among any kind of 12-step meeting attendance. We did differentiate between 12-step mutual help organizations and non-12-step mutual help organizations. So, for example, there are MHOs that are explicitly religious. One's called Celebrate Recovery, and that is really about kind of using Christian faith in the context of mutual help organization. And then there are ones, like I mentioned before, that are completely secular, like Smart Recovery. The predictor in these studies was 12-step recovery, 12-step groups, AA, NA. There's Cocaine Anonymous, Crystal Meth Anonymous, Marijuana Anonymous, on and on and on. They're all basically AA, but focused on a different substance. I mean, they all come from that 1935 AA model. Okay, and so the last study that I'll describe, one of the questions I had, and you guys might be asking this, is, okay, well, we know that you showed us that 12-step participation appears to be associated with benefit in that first year. But weren't they doing other kinds of things, other kinds of professional activities during that year? And maybe it was really those other kinds of professional services that were helpful to them and not the 12-step participation. Maybe 12-step participation is just explaining the same variance or something like that from other kinds of professional groups. So I wanted to look at, okay, that was a study of non-professional recovery support. Let's look at professional services that they got after treatment, and then also look at 12-step participation in context of those professional services. Does it have any effect above and beyond or unique effect, even when you look at some other services? So this is that paper again. If I'm happy to send anybody the actual papers. So for the sake of time, I won't spend too much on the rationale for continuing care in addiction treatment. But suffice to say that 28 days of treatment just is not sufficient to help anybody, let alone emerging adults with substance use disorder. When you look at naturalistic data, they're mostly among all adults, and they focus on older adults. But like Michael Dennis has done work showing that when somebody goes to treatment for the first time, it takes them on average 9 years to get 1 year of continuous abstinence. And in that time, there are approximately 3 to 5 treatment episodes. So it's a fairly bumpy road even for those who are quote-unquote successful. And there are lots of continuing care interventions that people have developed that have shown to be helpful for adults and for adolescents, not so much emerging adults. But there's some really good ones that show when you're exposed to that continuing care intervention, you're more likely to go back to treatment if you need it. You have better outcomes over time, and it's associated, which is important, with cost savings over time because it's more services. So that's always an important piece of this. Here we look naturalistically at continuing care services. They were not necessarily randomized to get one kind of continuing care service. So we looked at 4. One was more residential treatment. A lot of these folks, as you'll see, were actually referred to step-down residential care. They went to this 28-day intensive residential program. Then there was a less intensive residential program that a lot of them were referred to, especially in that first month or two. Outpatient treatment, so we measured that by just the number of groups they went to per week. Sober living environment, which a lot of people are now, I'm trying to get in the habit of calling them recovery residences. That's sort of the parlance now we're using. And the amount of time, the amount of days per follow-up period they spent there, and then whether they were taking some kind of medication for substance use disorder, whether it was agonist or antagonist, didn't really matter. And then just a quick note is, in this study, we modeled abstinence dichotomously. There were mostly for convenience of interpretation. We knew we were going to be looking at lots of different services at the same time, and so it just made more sense to be able to say being involved in this service and the odds at which somebody would be abstinent or not if they were involved in that service. You'll see it's just much easier to talk about odds ratios and get a sense of what that really means. And then the second piece is, in all of these studies where we're looking naturalistically at services or 12-step groups, and we're trying to say something about causality in the absence of really rigorous randomization or even really rigorous ways of kind of quasi-experimental studies like propensity score matching or something like that. We didn't have any of those. So there are different things that we do to try to improve our ability to make some causal inferences. And one of them is by lagging the predictor and the outcome. So like in the last study, I might have forgotten to mention, we were looking at time-lag associations between 12-step participation and abstinence. So participation at 3 months, abstinence at 6 months. Participation at 6 months, abstinence at 12 months, and looking at those two associations simultaneously, for example. This study, the lag models, the pattern of results were similar, but there were some really funky things when we lagged the models. Long story short is that it sort of created like a super group of people that were showing up for lots of different follow-up assessments, and so they were doing much better, and we just felt like it was biasing the results too much, so we used contemporaneous models. I can answer more questions about that after. Some descriptive 3 months, 6 months, and 12 months after residential treatment. The red bars are whether or not they were doing it. The blue line is the sort of continuous outcome. So 1 out of 5 of the emerging adults were going to outpatient treatment at 1 month, 3 months, 6 months, and 12 months roughly. Not that much, actually. You'll see why. And on the y-axis on the right tells us sessions per week. So on average, they were at most going to about half an outpatient session a week, which is not much. Here's why. They were really, a lot of them were going to residential treatment afterwards. Half at the 1 month follow-up, and a little bit less than half of the 3 month follow-up were in residential treatment at some point. But you see a decrement over time. So what this is telling me is there are actually different meanings of the residential treatment. Early on, it's a step-down residential treatment. Later on, it's probably more indicative of a relapse or the fact that they're doing worse. Getting medications was not very common. A couple of reasons. Remember, this is 2006, 2008. Just sort of the buprenorphine, also known as Suboxone, prescriptions and access just wasn't nearly as common. The opioid overdose crisis hadn't really hit. And this is a 12-step based program that wasn't offering those kinds of medications at the time. They do now. They do now. But Hazelden, where they came from, it took it wasn't until 2013 or 2014 where they incorporated medications, especially for opioid use disorder, into their treatment. The only medications these guys could get at the time in treatment, anyways, were psychotropics, antidepressants, and those kinds of things. Here's just how they engage with sober living. Again, the red bars are just whether they were in any kind of sober living facility or not, and the blue line is the average percent days they were spending there. And so what you kind of see is this pattern, right, where they're going to step down resi, and then they're linking them to some kind of sober living. By the time you get to 6 months, you see that jump, right? And this is a very common trajectory, an ideal trajectory. It doesn't work that way for everybody, but in the treatment world, where you try to keep them linked to recovery supports. And then here's their 12-step active involvement. That red bar, that means did they have those 8 activities I mentioned, did they have even one of them, right? So you see very very high levels of involvement, and those mean activities about 5. Now these are the dichotomous abstinence rates. As you might expect, you see a decline or a decrement over time, where 3/4 of them were abstinent for the first month after residential treatment, and that slowly declines as you get out to the 12-month follow-up. Now this slide, I am going to get up for this.
Plenty of time.
No, I know, but I'd like to just leave opportunities for us to discuss or whatever. So I'm going to run through this. So these all represent the effects of each service on abstinence over the entire post-treatment year. So it's 1, 3, 6, and 12 all in the same model. The blue, sort of take out the red bars in your mind for a second. The blue bars are looking at just the services themselves without thinking about 12-step recovery at all. And these are odds ratios. So what this tells you is that for every 1 unit change in the service, so for every 1 session of outpatient they were going to per week versus none, the group had 1.25 times higher odds of being abstinent across all the follow-up periods, in any given follow-up period. For residential treatment and recovery residences, these are really high because the 1 unit jump is from 0 to 100%. So meaning if they're spending, in any given follow-up, if they spent all of their time at one of these facilities, they had really high rates of abstinence, which you would expect if somebody's spending all of their time in a residential treatment program. Medication, there was no benefit for, right? Now, the red bars are the second model when we added 12-step involvement, right? So what you see is outpatient, no longer significant. You see an attenuation of the effect of residential recovery residences that are still significant. And you see 12-step involvement is a significant predictor of abstinence across the post-treatment year, even when you consider other services that they might have been getting. So what that 1.26 really means is for every 1 unit increase, so let's say compared to people that were involved in no 12-step activities, if you were involved in 1, your odds of abstinence in that post-treatment year were 1.26 times higher. And then it's not exactly like 26%, an addition of 26%, because it's like a log odds thing, math. But the average number of activities, right, that these guys were involved in at every follow-up was at least 5 out of 8. And so if you compare these emerging adults that had no involvement to those that had average levels of involvement, about 5 activities, their odds of abstinence were 3.2 times greater than those without involvement. And that was unique. Again, that's considering their initial, we adjusted for their initial motivation, how long they stayed in treatment, and all these other services that they were attending. So to me, that's a fairly compelling, that was a fairly compelling finding. The only thing here to say is that what was really most interesting, if you look at the bottom bullet, we looked at whether those effects change over time, and the effect of 12-step involvement actually got greater over time. At 3 months, it was not significant, but apart from that, it's sort of this linear increase. It's hard to know exactly what's going on there, but I kind of speculated, like, they're in treatment. As they're leaving treatment, whatever they gain from treatment is going to have less and less of an impact on how they're doing. And so these community-based services and what they're doing there is going to have more and more of an impact on their outcomes. There are other explanations potentially, but that's one that I like especially. Here's a study, a summary of the study. In this particular sample, residential treatment was actually pretty common as a step-down option, outpatient less so, medication less so. Residing or spending time in a structured recovery supportive environment after residential appears to be helpful. And part of the reason they seem to be helpful is because they're helping link people to 12-step groups potentially, right? So you see this attenuation of the effect where 12-step involvement appears to be, it's not a formal mediation, but explaining some of why, for example, recovery residences are helpful. I'm going to skip this slide. So here's just a brief recap of the 3 studies. I'm going to tell you a little about some future directions, and then I'm going to stop talking and we can have a discussion potentially. So in study 1, I showed you guys that emerging adults with co-occurring disorders respond as well during residential treatment as those that just have a substance use disorder. That abstinence may begin to tail off as you get to the end of the post-treatment year, but they generally do about as well in abstinence, and they show a similar response on psychiatric symptoms. One nuanced finding that I think is really interesting, although we don't necessarily know the implications, is that those psychiatric symptoms show just like a rapid, precipitous improvement in 25 days for everybody, pretty much. In the second study, I showed you that 12-step mutual help attendance, but especially active involvement, helps boost abstinence and may help buffer against kind of poor prognosis for those with co-occurring disorders, potentially, and that these 12-step effects in the third study showed you these 12-step effects hold up even when we're looking at other kinds of services that they might be involved in, and that these other services like recovery residences, what people call sober houses, might be helpful because what they're doing is providing a supportive environment where they're linking them to these evidence-based community services after treatment. The limitations are probably obvious to you guys in some ways, so I don't have to cover them too much. I'm trying to think if there's really anything I want to point out. Not really. These are all pretty self-explanatory. We can talk more about them. So for some future directions, and this is where my work has started to move, the first bullet is really nothing that I'm particularly, that I'm headed on in terms of my career path, but I do think that if people are using imaging to try to get a better sense of responses, of treatment and recovery-related response, I think it would be helpful to know, like, for example, if treatment is helping with the kind of mesolimbic system in the brain and the reward circuitry, maybe that is also helping account for or explain improvement, those vast precipitous improvements in depression, for example. Maybe it's, I don't remember her name, but maybe it's that treatment is helping with abstinence and whatever kind of healing is going on in the brain relative to abstaining, maybe that's what's accounting for kind of more activity in the reward centers of the brain. Relative. So it's hard to know exactly what's going on, but I do think they can actually help shed some light on that. This was a naturalistic study. Some controlled trials might really help tease apart what's going on, especially whether, like, is it that a treatment that's technically supposed to be just for those with substance use disorder, is that sufficient if it is robust enough and residential to also help those that are struggling with psychiatric disorders as well. And then the third bullet is really more where the last few years of my career have gone and where I'm hoping to go. It's, as we've talked about, it's both hard to engage emerging adults in these continuing care processes. So when they go to treatment, it's very hard to sort of keep them involved in recovery supportive environments, engaged in activities that are going to help boost their recovery outcomes or psychiatric outcomes or whatever. And then it's also really hard just to get them into any kind of care or service to begin with, which was different about this crew. So on the right, I just included a figure from the most recent National Survey on Drug Use and Health. Those figures are the percent of individuals that quote unquote need substance use treatment, which means they either met criteria for an SUD or they're actually going to treatment. That's what percent went to specialty care in the last year. They define specialty care as having gone to like an inpatient or outpatient program. Could have been for mental health too, but like AA doesn't count as specialty care, for example. But what you see is that 18 to 25-year-olds, we have a harder time engaging them in specialty care than 26 and up. We have a hard time engaging everybody in specialty care. There are a couple of reasons for that. One, I don't think that everybody who they say needs treatment really needs treatment. Having an SUD does not necessarily mean somebody needs treatment. Not the way that we think of treatment. So that's what I have started to do really, is think about, okay, what does treatment mean? We think about treatment being only for those that are most severe and requiring a major time commitment, whether it's a 3-time-a-week IOP or residential program or whatever. But when you ask people who don't go to specialty treatment why they don't go, yeah, there are issues with access to health care and insurance issues, but that's in 4% of them. and 96% they say they don't go because they don't need it, right? So now some people say, well, we have to use motivational strategies to help change their attitudes about going to treatment. Yes, I do think there's a piece of that is their attitudes and how those will change over time. I also think that's about the ways that we think of treatment as a paradigm. They're saying, I don't think I needed treatment because what they're thinking about when it comes to treatment is a residential program like these emerging adults went to, for example. So I started to think a little bit about, well, what are some other ways of thinking about services that will help, that will help engage young people that are in treatment but really unlikely to follow up services after, but then what are ways to engage people in services that won't go to treatment at all, especially young people? So that's really led me to this area of interest, and Kate mentioned my K award. This is really what my K focuses on, is trying to understand online recovery communities and whether we can take emerging adults. I'm starting with emerging adults that are in treatment already, although I'm hoping to branch out at some point to those that are not in treatment to try to engage that 93% of them who aren't going to any specialty care, right? But so I'm trying to understand if we link them and encouragely facilitate their involvement in some of these online recovery communities that don't just involve people but have recovery resources on them. And there are many of them out there that people are using, but we just don't have any earthly idea empirically whether they're helpful or make a difference. And so I have there are some questions around, this is a kind of fancy model that I think about, and I do believe that there's something therapeutic about engaging people with substance disorder in communities where they're able to see or speak to online potentially people that are in recovery, to be able to get a sense of, oh, this is what it's about, or oh, I really can't do this, or oh, I really do want it. That's the kind of stuff that changes their attitudes and beliefs, or a piece of it anyways. And so this K23 under review, my goal is to learn how to use social network sites to try to do a better job of boosting emerging adults' engagement in recovery kind of supportive services. Again, I'm starting with treatment-seeking sample, but I'm interested in this more broadly. And then so that's really the first aim, is to try to get a sense of what's the clinical utility of some of these online, what I call recovery social network sites. Can we get young people that are in treatment to use them? If we do, how do they engage with them? What kinds of things are they doing? What do they find helpful? And then does it make a difference in terms of their outcomes over time? Does it actually improve abstinence rates over time? The second piece I'm interested in is what risk factors might be present on social network sites in general. So this is less about recovery resources and more about data that are showing, especially for young people, that they're being exposed to lots of pro-alcohol and other drug content online, and that there's some data that are coming out of a lot of college labs. There's not really much clinical data, but they're showing that for college students that are reporting exposure to some of these, to content, whether it be on Instagram or Facebook or Twitter, that longitudinally exposure to more alcohol content actually does seem to be associated. We're not sure causally, but it looks like it could be causally related to increases in drinking over time. And they think it's because mechanistically it's changing their norms, right? So we know that social norms are going to impact how much young people are drinking. And when a young person's on a social network site, most of the time, other young people are not posting when they're home in their pajamas watching a movie or reading a book. They're posting when they're out drinking, right? And so what are already very skewed norms that young people have around how much their peers drink, we know that young people always overestimate how much their peers are drinking, and when you tell them they're drinking less, they tend to decrease their drinking. But the theory is that social network sites have actually increased how skewed norms have become, because it seems like their friends are drinking even more than they really are. So I want to get a little bit of a sense of that clinically to try to understand some of those dynamics. So this is my RI team. I want to introduce, that's John in the suit, second over from me. And as you could tell, this was taken in the summer. We don't dress like that usually. And just a quick plug. So my kind of day job, quote unquote, as I'm working on getting funding, is I work for the Recovery Research Institute, which is the name of our research program, but it's also this donor-funded initiative where we take the science on treatment and recovery sort of like recent articles, and we write summaries that we try to make them more engaging and easier to read than like a typical academic article. And so they're interested. I think that they can be helpful for scientists, but as a lot of clinicians sign up for the newsletter, and hopefully lay people that are interested in the topic. And so every month it's just a free, we call it our bulletin, goes out, and we summarize usually about 8 studies that are recent. Like there was a recent, like a hot study that compared Suboxone to Vivitrol, for example, that got a ton of press. We reviewed that one. And then we'll have interviews sometimes with other folks that are in the field. So just a quick plug for that as well. Just go to recoveryanswers.org and you can sign up for free. Follow us at Recovery Answers on Twitter.
You have a Twitter?
Yeah.
You have a Twitter?
Yeah, at Recovery Answers is our
Yeah.
That is it. That is my talk. Yeah, I don't know. I realized one of the things that's challenging for me, and slides sometimes help, but not always, is because this stuff gets so exciting to me. I can go off on tangents, right? And hopefully I make my way back to the point, but I realized I probably talked a lot there. Yeah, if you have any questions or need me to go back and clarify anything.
I have a few questions for
Get the party started.
So the part that you started talking about, which is sort of being in the social media and sort of how that influences that, is really fascinating. And it's certainly unique, probably even more, and again, I don't have to be on this, but probably more so influences the young adults than influences adults. Is there any sort of research out there on adults, regular adults, not necessarily sort of the young adults, about their influences, or is it more
not on social media influences? I mean, there are epi data on whether they're on social network sites. So like pretty much like 70% of U.S. adults are on social network site, but it's like 90% of 18 to 29-year-olds or something like that. Very high rates. But no, in terms of getting a sense of spending time on social network sites, exposure to alcohol and other drug content, and whether that actually influences actual substance use over time, that's been predominantly done in young people, and even more so predominantly done on college campuses. Very little of that research has been conducted in clinical settings, and very little of that research has been conducted in non-young adult samples.
Isn't that like all that research on, and probably more tobacco than anything else, but really sort of like the ads, and like you can't put ads in like certain age groups, right, and like movies can only have certain ads and things like that. Yeah,
that's a related field that I definitely am hoping to learn more about. But there is a pretty robust literature on marketing around alcohol and drinking for everybody, but especially I know for young people. But it's a related literature, so there definitely are things on like alcohol advertising, tobacco advertising, and adult drinking. But I don't know about social network sites. Yeah, like in terms of influences, the way that I think about social network sites is because they're being exposed to marketing. I don't know how different that's going to be than marketing exposure more generally, like on TV or whatever. I think what's different about social network sites is, or what I'm interested in, is the 24/7 access to their peer network and what peers are posting. A good example of that is like there was a study, I think in France, where it looked at folks in residential treatment, and they were trying to understand cravings and what kinds of things would trigger cravings. And they used ecological momentary assessment, EMA, and what they showed was when they were adults, when they were exposed to triggers, right, that led to a craving, but those triggers did not necessarily have any personal meaning. So they walked by a liquor store and they saw a billboard. The craving lasted for a couple hours or something like that. When that trigger had some personal meaning to them, a song played on the radio that they associated with their drug use or a person, or they saw somebody that was drinking and that they knew, the craving lasted twice as long. It lasted for 8 hours. So there does appear to be something particularly risky about being exposed to like kind of pro-alcohol or the drug content when it has some kind of personal or emotional meaning, as opposed to like a random billboard or something like that.
Yeah. That makes sense. And I mean, I can imagine it being sort of like, because sort of talk about forever in the criminal justice system, where you essentially age out of a particular thing, and now you have the neuroscience stuff that's backing the idea of sort of the developing brain, and when you have these times when it's really crucial, and so possibly, I mean, is there a way, or are you guys thinking about comparing it to sort of an adult population, not transition age? Because like, that to me feels like the core of.
Yeah, that's the R01 after the K23, or the R21 maybe at the same time as the K23. Yeah, at some point. Now, what's interesting, right, is I won't go back to the slide just because we don't have time, but as pilot data for this K, and as a kind of my foray into this area, I did this survey of individuals that were using the specific recovery social network site. It's called intherooms.com. So it's the largest one that I know of. It's got like 450,000 users. Not all of them are like active at the same time, but it functions and it looks just like Facebook. There's the wall and the news feed, and they have these recovery resources on there. They have live online video meetings that people can go to. It's very specifically, the social network site is very 12-step oriented. They're not all, but this one is. And I bring that up because I had to cut off the survey at 125 people because that's all I was able to get seed funding for. But a lot of them were older. We actually didn't get that many younger folks, and there were a couple of different reasons why. It was sort of, the recruitment went really fast. It happened in 8 hours, and it was the middle of the day, and so young people probably aren't on the site in the middle of the day, but like older people are using technology, and they're using technology to help sort of improve or maintain their recovery as well. So I don't think that we need to be focusing necessarily just on emerging adults. That's more like helping me kind of dovetail off the work that I had done from a grantsmanship perspective, and it's just a way for me to sort of like keep a handle on everything, and then thinking like, okay, if we can figure out this, then I'll move on from there and think about adults more broadly, adults outside of the clinical setting who are kind of refusing to get treatment, all these different kinds of things. But yeah, I think there's definitely a space for adult work more generally, but I haven't done it.
And one more silly question. And this comes from lack of familiarity with AA and NA.
Mm-hmm.
And so anecdotally, and from what sort of, at least in the criminal justice sort of realm, there is, the way NA is perceived is usually in a very negative way as compared to AA.
Yep.
And so is there, does that sort of...
I've heard that too.
And does that play out?
It's regional. The thing about 12-step groups is they're just people.
Yeah.
Right? So it really depends on the kind of meeting you're going to, where you're going to meetings. They look different depending on the region. For whatever reason, in like the Boston metro area, a lot of people just go to AA, and they see that as like the solution-oriented community group. And NA has that reputation of being the group that has people that are like chronic relapsers and this and that. So I have heard that too. I don't know that that's like borne out in the data. We actually don't know that much about NA on its own. The studies that have been done on 12-step groups, there's been a crap ton of studies done on AA for folks with alcohol use disorder, and a lot of studies like mine that combine all the 12-step groups into sort of one predictor variable. But there is a need in the field, and people have been talking about this for like an NA-specific study, especially because a lot of opioid users are going to NA, and they're getting some really strong anti-medication messages in there. And so there's been this really, there's been this big push. Most people are just criticizing, but researchers are trying to push for more research, right? So I do think we'll, in the next 5 to 10 years, I think we'll probably learn a little bit more about NA than we've known so far.
I would say it's not just Boston, Massachusetts, it's New York.
You've heard the same thing there, huh?
And so
Yeah.
even sort of like in correctional facilities, they don't discourage NA, but they're certainly much more progressive, like Rikers, the whole AA meeting.
So interesting, yeah.
And so I don't know what to make of it. Do people tend to go to both? Or
I would say in practice, people tend to go to whatever is convenient for them, like whatever they can go to. The kind of philosophy, you'll hear a lot of like vocal members who are like hardcore, they want you to stick to one fellowship or the other. Now, what's interesting is we actually did John was the first author on the study. This was this data set actually. And you could be mismatched, and it didn't make a difference in terms of your outcomes. In other words, if you had a primary drug problem, not primary alcohol, and you were going to primarily AA meetings rather than NA, your outcomes were just as good as if you went to primarily NA meetings. So at least in our data set, it didn't really matter whether they went to AA or NA. That might not be borne out everywhere else. But
Great. Well, thank you so much.
thanks you guys for listening.